Good afternoon, everyone. Thank you for attending our webinar entitled Hospitals, Investment in Housing: How Can Nonprofit Hospitals Address Their Patients' Housing Needs? My name is Kate Reynolds, and I'm a Policy Program Manager at the Urban Institute's Research to Action Lab, and I will be moderating today's discussion. Before I introduce our first speaker, I'd like to explain what we'll cover today. So first, we will present early findings from a survey sent to nonprofit hospitals on the state of their housing investment practices. Next, we will hear from Julie Trocchio of the Catholic Health Association about the community benefit provision of the tax code and recent changes to this provision. And then lastly, we'll discuss how some hospitals and health systems have approached making investments in housing in the context of the Center for Community Investments Accelerating Investments for Healthy Communities work with Robin Hackey. A few housekeeping notes. All attendees are muted. You may use the chat box at the right-hand corner of your screen to submit questions you have during the presentation. We will answer questions at the end of the presentation today. This webinar is being recorded and will be available as a resource on our website. With that, I'd like to begin today by introducing the principal researcher on this project, Erica Pothig. Erica is Vice President and Chief Innovation Officer at the Urban Institute. She leads the Research to Action Lab, an innovation hub serving decision makers and creative thinkers eager to affect social change. The lab draws on the breadth and depth of Urban's research insights to test new strategies, develop cutting-edge tools, programs, and trainings, and provide strategic advice to public, philanthropic, nonprofit, and private sector leaders.
Great. Thank you so much, Kate. It's a real pleasure to introduce this research project to everyone on this webinar today. So as you know, there's a need across the country for housing investment. Federal housing assistance only covers 1 in 4 households who qualify for these benefits. And this stands in contrast, I think, when you think about the ways in which Medicaid is a more universal benefit, but for housing it is not. So in some markets, demand for housing is increasing home and rent prices and destabilizing families, and in other markets, existing housing stock is diminishing due to disinvestment. So bottom line is that many times there's just simply not enough affordable housing or federal, state, or city benefits to house those at the bottom of the income distribution. Now, research shows that housing instability is associated with worse health outcomes, and in some cases, higher health care costs due to repeat emergency room visits and hospital readmissions. Hospitals, as anchors in their communities, can leverage their influence to fill gaps in the affordable housing supply. Now, it is for these reasons that we are pursuing a project to create a research-informed, actionable toolkit for hospital administrators and executives to equip them to understand the value of and approaches to investing in housing and community development activities. Today, we'll discuss the preliminary results of a survey of nonprofit hospitals to assess their motivations to invest in housing, perceptions of challenges of housing-related activities, and the state of their housing investment practice. This survey is an input into a larger project culminating in the Toolkit for Hospital Administrators. In February 2019, we will convene health system and hospital administrators and experts in the field to gather further information and feedback to inform this toolkit. Lastly, I want to mention that this work is advised by a committee of organizations that have advanced expertise in this area by conducting qualitative research, creating policy products, and providing direct technical assistance to hospitals and healthcare systems as they invest in communities. We will hear from 2 of these organizations today, the Catholic Health Association and the Center for Community Investment. We also want to thank the Democracy Collaborative and Mercy Housing for their guidance on the projects thus far. We're very excited and very grateful to use this collective wisdom of these organizations to help create a useful and impactful toolkit. Now, I'd like to introduce Michael Johnson, who will say a few words about the project as our generous funder. Michael is a Vice President in Global Philanthropy at JP Morgan Chase, a global leader in corporate philanthropy with more than $200 million invested in communities annually. In Michael's role, he is responsible for the firm's affordable housing and community development portfolio for the Northeast. He supports national work and thought leadership involving affordable housing, seed capital, and data-driven solutions for neighborhood revitalization through JP Morgan Chase's Partnership for Raising Opportunities, or Pro Neighborhoods. Prior to joining JP Morgan Chase, Michael held high-level positions at the New York Housing Authority and Brick City Development Corporation under former Mayor Cory Booker. With that, I will turn it over to Michael.
Thank you, Erica. The health of our communities really depends upon a number of factors. They include social, environmental, economic conditions. And the availability of these resources and institutions are really tied to stakeholders that are invested in these. So zip code and census tract really often determine the success. In this space, we've seen a number of community development corporations and nonprofits working to implement approaches that address the disinvestment and clear disadvantages that people are facing in their daily lives. On a parallel track, we're seeing transformative change in thinking in the healthcare industry. Hospitals and healthcare systems are shifting to consumer-driven healthcare models that seek more value-based approaches to patients' care. Hospitals are thinking about how to direct investments, implement technological innovations, and identify partnerships that will create long-lasting impact in meeting the health and medical needs of patients they serve. These two factors, the health of communities, health of patients, creates a timely opportunity and convergence of new ideas and a reimagination of how hospitals, health systems, CDCs, and communities can address what we have identified as the social determinants of health. At JP Morgan Chase, we agree and are closely aligned with this new thinking and approach. Believe that societal and health challenges are also business challenges. We are all intrinsically linked. So in turn, our success should be connected to the community success. Housing, as we know, is considered a place where we can start, since it's a platform for addressing the social determinants of health. For example, a 2013 report from the Journal of the American Medical Association indicated that the average life expectancy for the chronically homeless is 27.3 years less than the average American. So people living on the street are dying nearly 30 years sooner than those with shelter. We have successful examples of collaborations between hospitals and community development corporations across multiple markets, but we know there is still more to learn. Our partnership with Urban Institute, its team of thought leaders, and early findings of this survey research will help us to discover best approaches as well as actionable and scalable strategies that hospitals can use to make investments in housing. We look forward to your participation and feedback on these findings and seek your continual engagement and insight in the coming year. Now I'll turn over to Eva, Research Associate at Urban Institute, to present the findings. Thank you.
Thank you, Michael. There has been a good amount of qualitative research on the early adopter health systems and hospitals that have invested heavily in community development and housing. However, our research project intended to gain a better understanding of the state of housing investment practice in nonprofit hospitals across the country. We also wanted to expose the field to the questions and perhaps give hospital administrators new ideas simply by seeing the survey. We sent a survey to a random sample of 300 nonprofit hospitals and asked about their perspectives and current practices around housing-related activities. In the context of this research, by a housing-related activity, we mean allocating financial or in-kind resources to housing to address patient and community health needs. We include activities in which no return is expected. For example, if a hospital donates land to the city for the purpose of developing affordable housing, that would be included as a housing-related activity. This hospital may receive a tax benefit for this donation, but would likely not expect a financial return. As Erica mentioned, this project is unique in that the end product will not be a traditional research paper. Rather, the insights from the survey will help us in developing a research-informed toolkit that can be used by practitioners at interested hospitals to begin or expand their housing-related activities. We will hold a shared knowledge convening to gather input from hospitals and health system executives on February 7, 2019, here in Washington, D.C. This map shows all of the cities in which a hospital in our sample opened or responded to our survey. As I mentioned, we were interested in using the survey both to collect information and to expose the field to new strategies and ideas simply by reading the survey questions. It is my pleasure to discuss our preliminary findings based on responses of 30 hospitals from the first few waves of the survey. Because of the small sample size, these findings cannot be generalized to the population of nonprofit hospitals, but we think they are a good conversation starter and give us some sense of the issues we may want to explore in more depth in this project. To start, we wanted to know whether hospitals are aware of the housing needs in their patients or communities and whether hospitals allocate any resources to housing-related activities. Most hospitals in our sample said that yes, housing has come up as a need either through the community health needs assessment or other means, but a third of hospitals in our sample have not dedicated resources yet for housing-related programs or activities. We wanted to know why, so we gave respondents a few questions to pick from, as well as an opportunity to write in their unique reasons. Arranged in the order of importance, most frequently, hospitals said that they have considered getting involved with housing-related activities, but just don't know where to start. And then looking at other reasons picked from left to right, 3 hospitals said that housing is on their radar but have other pressing priorities. And other hospitals said that they would need technical assistance to get started, or that they would need help in finding the right partner. Only one hospital in our sample said that housing was just something that did not fit in their community health or social determinant strategy. One respondent, in additional comments, said that their hospital had no plans for housing due to the lack of knowledge about available incentives. A takeaway here is that most hospitals in our sample that are currently not involved in housing are thinking about it and say they might need help. Now, going back to the hospitals that said they do allocate resources to housing, we asked them to tell us more about the types of housing programs and activities they were involved in. We structured our survey question as a long list of common housing-related activities, which we identified in the literature and in discussions with our advisory partner organizations. And we asked hospitals to indicate whether they have done this activity, have plans to do it, or do not expect to do a particular housing-related activity at all. And here is what we found. Most hospitals in our sample said that they have shared data to support health and housing collaboration, made donations to affordable housing providers, or convened stakeholders around housing. Many hospitals indicated they are planning to get involved in housing advocacy and develop permanent supportive housing programs or offer clinical services at affordable housing sites. And although quite a few hospitals have done or are planning to do each of the activities listed here, most hospitals in our sample indicated they are not planning to donate land, provide rental assistance, donate funds to affordable housing development, or create a medical respite program. On these 5 areas, hospitals in our sample split about equally between those who said they have no expectations to get involved in any of these activities, and those who have done or are planning to deliver care to people who experience chronic homelessness, provide food assistance to people in affordable housing, provide home environmental assessments and repairs, build housing for their employees, or provide loans to affordable housing developers. A section of our survey was dedicated to questions about financial strategies that hospitals have employed to invest in affordable housing development, which we define as buying, constructing, or renovating housing. And I want to clarify here that by investment, we mean investing fixed or financial capital with an expectation of financial return. First, we wanted to know at what scale hospitals are investing in affordable housing development. And we found that only a small number of hospitals reported that they have invested in housing development, but most rather modestly, spending less than $250,000. We offered respondents a range of investment strategies to pick from, again, informed by what we learned from the literature and experts on this topic. And here are some of the results. Among the hospitals that have invested in affordable housing development, the most commonly used strategy involves utilizing existing real estate. For example, one respondent indicated that their hospital developed senior and low-income housing in donated hospital buildings. For investment approaches that hospitals are not currently using, we asked respondents whether they would be interested in learning more about these specific strategies. And hospitals said that they would like to learn more about working with community land trusts to create and preserve affordable housing. Another section of our survey asked questions about factors and policies we think have motivated or could motivate hospitals to get involved in housing-related activities. And we also wanted to tease out factors that may present challenges to housing-related investments. Overall, most of the hospitals that have dedicated resources toward housing-related activities report that improving health in the community was the primary factor influencing their decision, much more important than incentives, cost savings, or business needs. More specifically, hospitals are overwhelmingly motivated by a desire to improve health and well-being in their community. Reductions to ED visits and readmissions and market pressures were also cited as motivating factors, but much less frequently. Some hospitals indicated that cost savings and internal business needs, including needs of their employees, played some role in their decisions to fund housing-related activities. Almost universally, hospitals in our sample regard housing as a fundamental resource that can support health and well-being of people and communities. And half of the hospitals in our sample think that the healthcare sector should therefore be involved in housing. But hospitals also recognize that housing-related activities can be complex, resource-demanding, and extensive endeavors. To learn more about what hospitals think about housing-related investments, we asked survey respondents to indicate how much they agree or disagree with a set of statements that reflect some common themes in the literature on healthcare and housing partnerships. Presented here from the most frequently agreed on statements on top, most commonly, hospitals perceive housing investments as requiring significant amount of time before you can even see the results and reap the benefits, if any. And many respondents were not sure they understand and are willing to take on the risks associated with housing investments. On the other end of the spectrum, the least commonly selected responses from the bottom indicate that very few hospitals thought that there was not enough evidence on the link between health and housing, or that unmet housing needs should only be a concern when they negatively affect a hospital's finances. We also asked a few questions about federal policies that may affect hospitals' decisions around housing. And we found that 60% of respondents who answered this question were aware that the IRS issued a clarification that some housing improvements may be reported as community benefit. Slightly more than half of respondents knew that the tax cut bill that passed in 2017 created the Opportunity Zones program, which provides tax incentives for investments in designated rural and underserved communities. And about half or some of the respondents who answered these questions also said that these policy changes could motivate them to invest in housing-related activities. And finally, we asked hospitals, what would it take to increase their investments in housing? Again, we gave respondents a range of options, and most frequently, hospitals said they want clear evidence and data that housing-related activities improve health and reduce healthcare costs, followed by financial or non-financial support in making the housing investment. One respondent, for example, indicated they would be interested in learning more about how to leverage their experience, skills, knowledge, and staff to support housing development in addition to the funds the hospital can provide. Fewer hospitals indicated that they need information on how to make the business case for housing investments or value-based payment model. And with that, I will turn it back to Kate.
Thank you so much, Ava. At this point, I'd like to remind all of the participants that we do have the option to submit questions, and so feel free to do that at any point during the webinar, and we'll answer those at the end. And now I'd like to introduce Julie Tracchio. Julie is Senior Director of Community Benefit and Coordinating Care for the Catholic Health Association of the United States. She coordinates the CHA activities related to planning and reporting community benefits and leads the Catholic Health Association's advocacy on the charitable purpose of not-for-profit healthcare. Prior to joining the association, Julie was Director of Standards and Quality for the American Healthcare Association. She's held nursing positions in acute care, long-term care, public health, and school health programs. And we're delighted to have Julie on the webinar with us today to discuss community benefit in light of these research findings.
Thanks very much. I'm delighted to be with all of you today. I'm here to present the perspective of hospital community benefit programs and to tell you, as I said earlier, a little bit about the IRS requirements and what their thinking is. When I look at our community health needs assessments and community benefit programs over the last, especially the last year, I'd say we have two major trends going on. First is much more attention to the social determinants of health, and also much wider and better collaborative relationships with community partners. And I think both of these have so much to do with housing. Now, when you look at the social determinants of health, and I mean those factors that go upstream that cause some of the major health problems in our communities, it seems like a no-brainer that, of course, that's community benefit and ought to be part of what hospitals do when they address community health needs and should be reported as community benefits. But it didn't seem that way to the Internal Revenue Service when it first developed the reporting form for hospitals, and that is the IRS Form 990 Schedule H. When we presented, and by we I mean the American Hospital Association, the academic medical centers, other hospital organizations, along with the Catholic Health Association. And we showed the Internal Revenue Service what are the most important categories. If they wanted hospitals to report, how might they group them? And our final category was called community building. And that category included housing and along with environmental and some other activities that we think are so important that get to the root cause of problems. Now, the IRS people who are really smart, but they were tax lawyers, they weren't public health people, said, but we give you tax exemption for providing health care, and when you do housing or education or the environment efforts, how is that health care? Well, we argued very well, and I think Michael Johnson talked about, and he cited some studies, that there is such a close tie between these determinants of health, especially housing and health. We know that someone cannot be healthy if they don't have a stable and a healthy environment in which to live, if they don't have a decent home in which to live. And so there was really quite a campaign trying to convince the IRS, but still, when they developed their first form, they put community benefit in one part of the IRS reporting form, and they put community building, which included housing, in a separate section in a part two. Well, that was a problem for hospitals because many researchers or press people or others only looked at part one. They never got around to part two. And we were afraid that it might discourage some hospitals from getting involved in those upstream activities. So we worked really hard with the Service and the Treasury Department. By we, again, was all the hospital associations. And we did have some success. A couple of years ago, the Internal Revenue Service changed its instructions and said if an activity that's listed among the community building activities, if that activity meets the definition of community benefit, and that would be that it addresses a community health need, and secondly, that it addressed a community benefit objective, and one of the objectives is improving population health. Then it could be reported not in the part two, but in the part one. This is getting kind of nerdy and into the weeds, but I think it does get important because when legal departments, when compliance people, when boards want to know what are we doing in community benefit, they want to look at the 990 and they want to see all of our activities. So it's important that we can report housing there. Finally, even though they changed the instructions, many of our folks, many hospital people said, well, it's there in the instructions, but it still says in part two, housing and other activities. So we'd like to see more. So in 2015, at the end of the year, the Internal Revenue Service issued something that they called an executive order update. And there, I'm going to quote you for a second, some housing improvements and other spending on social determinants of health that meet a documented community health need may qualify as community benefit for the purposes of meeting the community benefit standard. So that was just great news for us. So now we think there is no doubt about it. When hospitals are involved in housing activities, we can report that as community benefit. After that clarification came out, CHA worked with Enterprise, and we developed a paper on what can be reported as community benefit in the housing arena and what should not. For example, we said that when hospitals work with community partners to get rid of asthma triggers in a housing project, that would count as community benefit. When we invest in housing for our own employees, that would not count as community benefit. So anyone can go on our website and look at our housing paper, and we welcome any comments on that. Well, when we look at our community health needs assessment, these social determinants of health, as I said, come up. And I would say the three most important and the most frequent are food security, transportation, and housing. Housing comes up over and over. So over the past year, the Catholic Health Association has been looking at what can hospitals do to address these determinants of health, including housing. And we know we cannot address these by ourselves. This is not necessarily where our expertise is. This is not where most of our resources can go, because we do have to take care of the basic health needs of people who come to our facilities, but we want to be part of the solution, and we want to be at the table when these things are addressed. So we have defined the role of hospitals, or suggested to our members the role of hospitals is threefold. First, it's clinical, so that when we take care of patients in the emergency room, in our primary care, upon discharge, that we screen for housing needs. We ask, do you have a safe place to live? Do you have a home? Do you have a place where your insulin can be kept cold? And so that we screen for housing security and housing quality, because that has a lot to do with that person's going to be well and be able to be safe once they get home. The second area is in the community, and we think that's probably one of the most important, that we work with community partners in addressing health, in addressing housing needs. So who in the community is looking at housing needs, who's looking at homelessness, who's looking at housing quality, who might we work with to deal with some of the problems that we've found in our community health needs assessment. So working with community partners is important. And then finally, in our operations. So in our policies and procedures, as we go about our daily work of running our hospitals, how might we address the social determinants of health? And in housing, that might be taking part of our investment portfolio, and I think Robin might talk to that, and invest that, whether it be low-income loans or some grants to community organizations. And the other place is just about all of our organizations have advocacy departments. They have some expertise at dealing with local and state governments, and can those people who have that expertise, can they also advocate for housing? So often the hospital's voice can be nice and loud when it comes to joining forces with community partners who are concerned with housing. So just in summary, I'll say that the interest in hospitals, in housing is very clear. I think Eva's presentation was just so clear on that. But the other part that I heard from what she said is that hospitals often don't know where to start. They want to know what are some of the financing options. They want to know what they might do in addition to investing. What are the scope of housing-related activities that could come. So I think that this study and the toolkit that Urban Institute's going to be developing is coming just in the nick of time. And with that, I'm going to turn the program back to our hosts.
Thank you so much, Julie. With that, I will make my second announcement about any questions that audience members have. Feel free to submit those, and we'll have Julie, Robin, Ava, and others able to sort of field those questions at the end of the presentation. And now what I'd like to do is turn it to our last speaker, Robin Hackey. Robin is Executive Director of the Center for Community Investment at the Lincoln Institute of Land Policy, which is dedicated to overcoming disinvestment and improving opportunity so that everyone has a fair chance to lead a healthy and productive life. Working with cross-sector partnerships, innovative health institutions, and local leaders, CCI helps set the stage for investments that advance opportunity and make communities more cohesive, resilient, and environmentally sustainable. Robin is a former venture capitalist and investment banker with more than a decade of community investment experience. And today she'll be discussing best practices from her work leading the Accelerating Investments for Healthy Communities program.
Well, thank you very much for having me. I am a great admirer of the Urban Institute and of Julie's work, so I'm delighted to be with you. And I think you guys are going to advance my slides, so if you can go to the next one. So the venture capital community loves to say that the future is here now. It's just not evenly distributed. And the Accelerating Investments for Healthy Communities program was our effort to learn really what's possible now by working with the pioneers, the health and hospital systems who are already using their resources to invest in affordable housing. And the program really asked a couple of questions. What did it take for these pioneering systems to get there and do this work? And what would it take to accelerate and deepen their investment still further? And then how might their experience light the path for other systems? Next. So we worked with 8 systems. And what was interesting about these systems is that they represented a variety of types of hospitals and health systems, faith-based, children's, safety net, academic medical centers. There was no one type of health system that had a premium on doing this work. And they also were using different strategies. So some were very much pursuing what they thought of as population health strategies that were aimed primarily or exclusively at their own patients and people covered by their health plans. But others, and in fact most of the cohort, were health systems that were focused on community health. In other words, they had a commitment to all the residents of their geography and not just the ones that were specifically their patients. Next, please. And what we learned from working with these hospitals in a 5-month, fairly intensive program was that there seemed to be 5 levers that really made a difference in the effectiveness of the programs. And I'd love to go through each of those and think about, what we might take away from the experience of these leaders that's relevant for other folks. So the first was, if we can go to the next one, creating cross-disciplinary teams. What we learned in starting the AIHC program was that when people think about the social determinants, they tend to default to thinking about their community benefits programs, which are obviously a very core, important part of what it would mean to use hospital assets to go upstream. These departments tended to have grant money at their disposal, so obviously very flexible resources. They tended to have excellent ties to the community, closer than other pieces of the hospital. But community benefits folks were not financially savvy people, and they didn't have access to the investment assets or the land or the other resources of the hospital. And so when we encouraged people, in fact required people to nominate cross-disciplinary teams that included all of the different departments that you see listed here, what we found was that these folks were very often working in the same system but meeting on the plane. The silos within institutions were sufficiently rigid that people didn't know all of the activities that were possible for the hospital to do, and that the focus of these different departments and the language that they spoke was often quite different. And by bringing them together, we were able to see a much more comprehensive view of how the hospitals could advance housing investments in their communities. And I'll talk more about that in a moment. But having the ability to see all the benefits that these investments would have across the institution, not only in terms of financial return, but also in terms of improved relationships, in terms of political capital. It was really an important realization for top leadership in the hospital that I think was a bit of a breakthrough. What we saw as people increased their commitment to doing this work is that they tended to then think about creating an executive position that would be charged with this cross-disciplinary work. And sometimes the right person for that position would come from outside the existing hospital system, bringing with them community development experience or urban planning experience. People were getting these folks from different places. Okay, next. The second finding, which was interesting, was that by using the same dollars that they were using already for community benefits work, health systems could really get more bang for their buck by deploying the grants strategically. And what we meant by that was that they could use their dollars in order to build a capital stack and essentially take the risk out of some of these investments for financial investors like banks or insurance companies, or in fact for their own purposes, and think differently about what would it mean to use their grants for programs that would return those assets to the hospital for reuse and redeployment after the housing was completed. And we saw different examples of what that could look like. So Nationwide Children's Hospital in Columbus, Ohio, one of the participants in our program, created a capital stack using hospital guarantees to attract bank investment, and JP Morgan Chase was one of the investors in that program. Boston Medical Center, a safety net hospital in Boston, used its grant dollars to invest in what's called a structured fund, where different layers and different types of investors got different returns. Boston Medical Center actually used grant money and did not expect necessarily to see those dollars again, although it's likely that they will. But they use them as equity in this Healthy Neighborhoods Equity Fund. So the idea that you could blend different kinds of capital from differently motivated investors was a way that hospitals saw that they could get greater bang for their buck. Next. The hospitals also had assets that they hadn't necessarily thought about to use for housing. And so in terms of financial resources, we saw participants in our program using all different kinds of hospital financial resources, sometimes a percentage of net operating income, sometimes a percentage of endowment or gift funding, pensions, insurance reserves, cash reserves. There were really a variety of sources that as soon as the finance people got involved, they could start thinking about how to be a little bit broader spectrum beyond community benefit dollars. We also saw that some systems had what they were considering excess land, which could be donated or used at below market for the creation of affordable housing. So that was a very tangible contribution to housing. Then there were some kind of more sophisticated approaches, like using strategic location decisions. So by putting clinics or doctors' offices in mixed-use buildings with housing on top, the health systems could become master tenants and make the viability of those mixed-use projects more certain. We also saw the use of totally non-financial assets. So as Julie was talking about, hospitals have significant influence, particularly on policy issues that can affect positively the health of their communities. And we saw some really powerful examples of what that looked like, and I'll talk about that in a moment. Next slide. So if the hospitals were able to take a step back and get beyond, the desire to do one project, to really think about the housing ecosystem and the community investment ecosystem in their places more broadly, then they could think about all the ways that they could help create a pipeline of investments, not just one, because it's like Lay's potato chips. One 20-unit project is not going to solve the housing needs of any community, and also how the hospitals could shape the enabling environment. So let me give you the example of Dignity Health. Dignity has one of the longest standing programs for investment in community development financial institutions and developers of affordable housing, and they've deployed about $100 million of their funds in these investments over a long period of time. What Dignity did as a result of thinking about one of their places, San Bernardino in this case, is they realized that they could not only invest their own funds in affordable housing transaction in San Bernardino, which as a place recently out of bankruptcy didn't have the municipal capacity to really be very helpful in generating community investment possibilities, but they went beyond their own investment in the affordable housing development. They convened representatives from the state Strategic Growth Council, from philanthropy, national philanthropies, as well as local folks, from CDFIs that didn't have a presence in San Bernardino, from developers and from banks, and they made people aware of what the opportunities might look like in San Bernardino and the importance of addressing the housing needs there. As a result of their doing this convening and articulating the case for investment in San Bernardino, they were able to get a $20 million investment from the Strategic Growth Council in California for this affordable housing project that had been stalled, resulting in the creation of 200 new units in a really strategic location in the city. So this stepping back and thinking systematically, how do we not only deploy our own financial resources, but how do we look at the larger needs of the investment system and act strategically to meet them, can be really powerful. Next. So as Julie mentioned, this is not work that hospitals need to or should do on their own. There are a variety of other stakeholders with experience and interest in doing this housing work, and we have seen the ability of the hospitals to reach out really effectively and strategically to these different partners. And each one brings a different set of assets, some financial, some not. But when the table gets convened to talk about these things, not on a project-by-project basis, but on a kind of we want to meet the needs of our community writ large basis, then some powerful things really become possible. We sometimes say that you solve the problem by enlarging it and by saying we're going to contribute as a hospital not just to one affordable housing deal, but to meeting the affordable housing needs of our community. you can sometimes get others to be involved in ways that they had not anticipated. If you remember the old children's book, Stone Soup, I have a carrot, you have a potato, together we have soup. So on that optimistic note, next slide. There we go. I would like to offer a couple of resources. We are really committed to making this work possible. We believe that it's the future, that it's doable, that hospitals have an important contribution to make. It looks scarier than it has to be. And with CMMI talking yesterday about using Medicaid funds potentially to fund social determinants in housing, there may be some new opportunities that are really exciting to think about. So we invite you to look at the resources on our website, to read the article that Julie was kind enough to publish earlier this month on ways that hospitals can use leverage with their community benefit dollars, or to be in touch directly, and we're happy to help. Thank you.
Thank you so much, Robin. So with that, I will use the remaining time here to discuss some questions and comments that we've received throughout the presentation from all of you. So the first set of questions has to do with the research itself. So Melissa Johnson from the University of Pennsylvania Hospital and Michael Badakin both asked about the survey sample. So the questions are, how many hospitals were surveyed, and what was the size of the hospital survey sample from Michael Badakin? And I'll turn it over to you, Ava.
Sure, thank you, Kate. So we drew our sample from the American Hospital Association survey data, and the sample was a random sample of 300 nonprofit hospitals, which we stratified by size and geography to increase the likelihood that our sample would be nationally representative of all nonprofit hospitals in terms of the state they're located in and hospital size defined as the number of beds. We also oversampled on a number of characteristics that we thought could increase the likelihood of a hospital being involved in housing or being interested in learning more about housing. For example, being a church-affiliated hospital or participating in value-based payment models or having an insurance product were some of these characteristics. In addition, we also sent our survey to a small sample of early adopter hospitals and health systems, which are systems that are known leaders in investing in community development and housing activities. And I guess the question about how many hospitals are surveyed is really related to how many hospitals responded to the survey. So the survey was filled online for 2 months through beginning of August through mid-October, and our overall response rate was about 14%, which totals 45 hospitals that have completed or submitted at least a partial response.
Thank you, Ava. Okay, the next question is submitted by Mark Thomas, who's Director of Mission Integration at Providence Memorial Hospital. He asks, and I'm going to direct this, Julie, to you in the first instance, and then we may see if others have answers. He asks, our Medicaid ACO interprets prohibitions on using dollars that originated via Medicaid, even after the dollars move from a global budget to shared savings, to purchase bricks and sticks. Can you speak to this?
Wow, what a great question. I am not an expert at the ACO rules. Those are, for those who don't know, accountable care organizations that get a capitated amount. And I think there are very specific things that can and cannot be used as an expense for that. I don't think there would be any problem in using community benefit dollars, but that is something that Mark, if you send me the question, I can try to research the answer. But there could be somebody, maybe Robin's familiar with that.
Nope, sadly I'm not.
I think it reflects, though, the issue that hospitals are really trying to be creative in finding here's a need, what can we possibly do? And I congratulate you on thinking that this might be a possibility. So,
this is Erica Posig, and I have very limited knowledge of what this may mean, but the CMS director, HHS secretary, just gave a speech this week where he inferred that HHS was going to be looking for ways to loosen the regulations around these particular issues. More than that, I do not think he said. You all may have also seen this speech referenced. So it's maybe something to be on the lookout for, to see if there's any more flexibility along these particular lines. But if, Julie, you're willing to research it, that sounds like a great offer.
Excellent. So the next question comes from Jean Eng, who's Director of Community Health at the Advocate Aurora Health System. And she says, where can we find some key resources prior to the toolkit being developed? So I'm going to turn this over to Robin Hackey, because I do believe that Robin's group has a number of resources which were highlighted on her last slide in particular.
Yeah, so it depends what you're looking for. The paper that you see a picture of on the left is a paper that talks about all the different roles that hospitals play in the community investment system and goes into some detail with examples about what that looks like. The article on leverage talks about how community benefit dollars can be used either in what's called a capital stack or to help prepare deals to be ready to be investable. We also have been writing about the progress of the hospitals in our AIHC program, and you can find that in the blogs on our website. But we are releasing a number of additional resources over the next few months. And so if you were to subscribe to our newsletter, which you'll see the subscribe button for on the website, you'll get them as they're hot off the press.
Thank you, Robin. We have one more question that may be directed to, I think, either Julie or Robin. And this is from Mark Thomas from Providence Memorial. And he says, can you speak to any examples of critical access hospitals investing in housing initiatives?
Julie, do you want to talk about Secours, and I'll talk about Boston Medical?
Well, I think the question is specific to critical access hospitals, which are really small rural hospitals. I did hear of a hospital in a very small. I'm not sure if it's a critical access hospital, but I know it's small, only 25 beds. And this is something interesting that it did. It took its community benefit dollars and it funded a full-time grant writer, and gave the funds for that grant writer to the local United Way. And then community organizations could use that grant writer to see if that person could apply for grants for them to meet community health needs. And the result was, I think, from maybe a $50,000 investment, they brought millions into the community. So that's just an example. I'm not sure if housing was one of them, but as the person who wrote probably knows, a critical access hospital is usually small, often under 25 beds. We are seeing them closing at a very alarming rate, which is very dangerous for their local communities. They're in rural areas. But I haven't come across any, and I don't know if your research, Robin, talked about some of these small rural hospitals and if they're able to do this sort of thing.
We have not run into hospitals doing it that way. What we have seen is, as a condition of approving mergers, which sometimes lead to hospital closures, we've seen that there are requirements being imposed by the state about what kinds of investments need to be made in order for the mergers to be approved. And so we have seen some of that, but it's not exactly the same.
Thank you both. We also had a couple of questions that were similar in nature, asking whether you can get a copy of the presentation with the initial findings. We will be posting the presentation on the urban.org event page, so you'll be able to find it there. And then lastly, we had one last question for Julie from Kimberly Lutz, who's Division Director of Community Outreach with the Hospital Sisters Health System in Central Illinois. She said during Julie's presentation, she referred to a housing document on the CHA website. I was not able to locate it. Where can that be found, and what is it called? Thank you.
Okay, CHA's website, we're frequently going back to it and seeing how we can make it clear for people to find things. But if you go to the website, and hi to Hospital Sisters Health System, and look at community benefit, and from there, look at what's new. Housing and community benefit, what counts should be there. Or if you go to the what counts section. Also on that website is a direct email to me, and just contact me and I'll make sure that you get a copy.
Thank you, Julie. You're getting a little bit of homework through this.
Well, this is why we did it, so that people can find it.
Yeah. Excellent. So with that, I want to wrap today by just talking very quickly about some of the next steps, which you already heard about, but just to bring it all together. We will be having what we're calling a shared knowledge convening with hospital administrators and experts here in Washington, D.C., February 7th of 2019. Please be in touch if you're interested in attending that event. And we look to launch the toolkit in spring of 2019. And we hope in that toolkit to really speak to some of the challenges and gaps that were sort of raised in our initial research. So providing financial decision tools, case studies, and some samples of IRS reporting. So with that, I'd like to end today's webinar. I want to extend a huge thank you to our guest speakers, to Michael Johnson from JP Morgan Chase, Ava Allen, our lead researcher on the project, Julie Trocchio, and Robin Hackey. Thank you so much for being with us today.
Thank you.
Thank you.